All right, I'm back again. The problem, though, is that when the diastolic filling is impaired and the ventricle is stiff, you can't get as much into that ventricle, and so pressure's back up. Now, there you go. Stiffness without thickness. Normal systole, diastole, restrictive. Notice there's not much difference between the two. The heart muscle doesn't move well. It doesn't relax well, actually. It contracts okay enough, but it doesn't relax well. Manifestations are going to be similar to heart failure, especially the diastolic heart failures. They'll do an endomyocardial biopsy to see if they can identify what the problem might be. There's no specific treatment. A lot of these patients require heart transplantation. The patient is taught to avoid situations that will further impair ventricular filling, like strenuous activity. You don't want their heart rates to be really high because you want as much diastolic time as you can. Dehydration is another thing that should be avoided. Cardiac transplantation. Rather interesting subject. The first heart transplant was done in 1967. The criteria: cardiogenic shock that's refractory, dependence on inotropes. I mentioned earlier that 50% of patients have cardiomyopathy. 40% of them have coronary artery disease that's inoperable, such that it's affecting their heart function. They have to have cardiogenic shock. In infants and children, most cardiac transplants are congenital heart disease related. Many people die waiting for a heart. There were about, in 2008, my numbers are 2163 heart transplants. In 2007, 2210. So, right about 2200 heart transplants a year. But thousands more would benefit if more donated hearts were available. Most transplant recipients are men. That'd be about 72%. 65% of heart transplants are white. About 19% are between the ages of 35 and 49. And 54% are 50 years or older. These are 2009 statistics. A one-year survival rate is 88% for men, 77% for women. And three-year survival rates run around 78%. A little bit of difference between men and women. Getting a heart transplant is not just about getting a heart. And, someone might ask, well, why do white men get more hearts than men, black men get? And it's about matching. And the donor pool, minority, for various reasons, do not donate with the same, numbers as Caucasians do. I think that some of it may be related to trust issues, healthcare trust issues, but it's about the match. Immunosuppressive therapy will begin in the OR. These are some of the examples of immunosuppressive medicines that are used. The infection is going to be your primary post-op complication. Your endomyocardial biopsies are going to be done, and T lymphocytes are monitored. The way that an endomyocardial biopsy is done is from the right ventricle, that's where the biopsy is taken, through the right IJ. So the physician accesses the right IJ, that's the right internal jugular vein, to get to the right atrium and the right ventricle, and then they take a biopsy. They'll do a biopsy every week for a month, every month for 6 months, and then every year. And what they're looking at is they're looking at symptoms, or looking for symptoms of rejection. If there are any, then they make changes in the immunosuppressive therapies. Bridge to transplant, a little bit more about the vascular access devices. Here you can see, I think I have these in there because they're just cool pictures. They pretty well are the same design as the other picture I showed you. This part is all internal, okay? And then this kind of gets tunneled. Remember when we talked last semester about PD catheters, peritoneal dialysis catheters, and how they're tunneled under the skin? This is also tunneled under the skin. This from here to here will be tunneled under the skin. That helps minimize risk. So the pump motion is here. This is the HeartMate pump. I actually watched one of these be implanted. They also have dual ventricle versions. This is a left and a right heart pump. And I don't remember if I said so as much to your to this class or not, but I remember how impressed I was. First of all, it was a huge room. There were more people in that room, it seemed to me, than is in the classroom when you guys are all here. Maybe not, but boy, there were a lot of people, and they all had an important job to do. I remember the anesthesiologist, they were trying to get the patient off the bypass pump, and his pulmonary artery pressures were really high. And they were thinking it was because his right heart was failing, and they were getting ready to break the box to get a right heart pump out as well. They'd already placed the left pump, but they were having a hard time, and they had it working, but the pressures were so high on the right side of the heart, they thought they were going to have to put a right heart pump. And the anesthesiologist said, no, let me bronch him. Let me see what's going on. And he pulls out a bronchoscope. I don't know where he got it. Somebody probably brought it to him. And he bronched the patient through the ET tube. You know, the patient was on a ventilator, totally anesthetized, you know, out and asleep and all that good stuff. And he sucked out a bunch of junk out of this man's airway, lavaged the airway, cleaned it all out, and lo and behold, pulmonary artery pressures came back down to normal. And because of that fast-thinking physician, he did not have a right heart pump placed. And you know, these pumps are with, you know, they have risks and stuff. So you don't want a right heart pump if you don't need one. I asked somebody if that was a common occurrence. They said, oh no, they'd never seen that happen before. That, you know, that a right heart was under such pressure because of secretions and stuff collecting in the airways. Here you can see this in this picture, and I don't know what kind of a pump this is. This is all external. I would say that this is a much more temporary device than this would be. The ABACOR artificial heart has 4 main parts that are implanted inside of the heart. It is approved for use in severe biventricular end-stage heart disease, in patients who are not eligible for heart transplant and don't have any other viable treatment options. I think the longest that anybody has lived with this is 512 days. 14 patients as of April of 2011. 14 patients had been implanted with the ABACOR, totally implantable pump. Well, no, I don't want to do that. But they're not very common. And I'm not exactly sure how all this stuff works, but you can see it's all implantable. And that is it. Now I will put up another section that you can look at if you want to. You're not going to be responsible for it. It's just kind of some interesting stuff on the history of heart transplant. That'll be in the next section.